So here we go. Exam to review. So we sent out a PowerPoint. We sent it out on Sunday, I believe. I'd gone over it, checked it, made sure that what I wanted to see in there was there. So it is a lot of information. So remember these definitions. You're going to see them scattered throughout this exam. So I like to make little 3x5 cards, put the name on front and what it means on the back. And that's going to help you to understand that. I know sometimes it's the visual for me, but whatever works for you. I've had students tell me that they make their children test them, or have them say, okay, what does this mean, or this definition, what it is. So whatever works for you, use it. So first of all, we're going to talk about some general terms. Meningitis. This is something from stuff. So some of you have not had that yet, or my class on Friday, but we're going to be talking about it. Meningitis is an inflammation of the covering of the brain, which is called meninges, right? And it also covers the spinal cord. Meningitis is due to what? Well, it's some sort of infection of some sort, isn't it? It could be viral and it could be bacterial. Encephalitis, again, is another inflammation, but of the brain, not of the lining or the meninges, meningitis. It is the brain gets inflammation there. Osteomyelitis, when you see itis, remember itis is an inflammation or infection. Always remember that when you see it at the end, itis. Osteomyelitis, osteo is a bone, so it's an infection of the bone. Osteo, again, bone sarcoma. Sarcoma is a cancerous tumor. So osteosarcoma is a malignant bone tumor. Now, Reye syndrome is an acute non-inflammatory encephalopathy, which means all of a sudden you get confused and disoriented, and then it's a hepatopathy, which means it gets to your liver too. Reye syndrome is caused by giving children aspirin. You should never, ever give children aspirin. Aspirin is something that is only given in one diagnosis and only under a doctor's order. So we will not give our children aspirin. Now, sepsis. What is sepsis? Well, when the body gets a bacteria, virus, or a fungus into the body responds to it, okay, to try to take care of this infection, whether it's bacterial, whether it's virus or fungal, and it tries to get rid of it. It puts out white blood cells and all that to try to smother it and kill it. That's sepsis. What do you see with sepsis? Elevated white count. We're going to see probably a temperature with it and probably a general feeling of, I don't feel too good. Conscious sedation is the administrating of drugs which impair you, conscious sedation, let me tell you when I've used it. I have had a child come into the ER, bilateral broken wrist bones, the radial and the ulnar bone. And they needed to be sort of put together and a cast put on, but they couldn't do it just with some morphine. We needed to knock the child out, but they maintain their own airway. So we put a little oxygen on them, but they still can breathe, but they do not remember what's going on. So the consciousness, I tell them to go to a place they like. You like basketball? Go to playing basketball. Do you like the beach? Go to the beach. And literally that's where they go. And they wake up and don't remember a thing. And then when they're done, all of a sudden they'll wake up and they're okay. And it's wonderful. You don't have to go to the OR. Now, clinical pathway is what we know is going to happen to certain diagnoses and what we need to do. So it's what x-rays we need, what labs we need, what drugs we need. What do we need? The interdisciplinary plan of care. that it will go from when you're diagnosed until discharge. These things will be done on day 1. These things will be done on day 2. It tells you, it describes it, and it's the entire treatment. Today, many physicians will say, do the clinical pathway for myocardial infarction and sign it. And it's already laid out for them because it has been found a good way to treat. An emancipated minor is an adolescent who's no longer under their parents' authority and they can sign consent. Well, emancipated minor could be a young one with a court order. Remember, in pediatrics, age 18, cognitively aware, they will sign for their own treatment. And we must ask the child if we can tell the parent what those lab results are, what the x-ray was, or to be in there when we're questioning them. At 18, you are in charge of your own care. And it will be a HIPAA violation if we give parents information. Okay, last exam, we went over and we had a lot of these developmental theorists. You will see them again, okay? So again, go back and look at them. Remember, Freud's all about sexuality sort of stuff. Oral, anal, phallic, latency, genital. I mean, I think the one that's the most confusing is latency because all it means is children in the school age time only want to really interact with the same sex peers. But besides that, oral, everything in their mouth, comfort, exploring the world. Anal, potty training. Phallic is when boys like the moms and girls like their dads. It's just part of that. And then, of course, genital is, adolescents and they become sexual, opposite sex. So again, stages of orality, which the infant explores the world in their mouth. I mean, what do? Pacifier, fingers, toys, blankets, everything in their mouth, right? Anality, of course, this is your toddler. It's that potty training. Remember, toddlers are all about no, 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 mine, 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 mine. That's all what toddlers do. Now that phallic stage, it corresponds to preschooler. It's called the phallic opival stage. That has to do with they're starting to be aware that I have a penis and you don't. Okay, it's now they come in the bathroom and see mommy and goes, but you don't have a penis or whatever you have named it. That's what that means. And again, latency is all about same-sex peers as friends. Now, Piaget. The one thing about Piaget is to know that there's 4 big stages, then there's subsets in there. So we know that sensorimotor is all about curiosity, knowing that how things, you shake a rattle. It's knowing how that you can call somebody in and get you. That's that object permanence. Again, remember, Piaget's all about thinking and figuring things out. Object permanence is, yeah, that toy is still there, even though I don't see it. I remember I'm going to go looking for it, and the older kids will crawl to it. The bigger kids will go to the toy box and grab it because they know it. Pre-operational is all about their imagination. This is where you'll see them riding on a broom and they think it's a horse, right? It's also part of how do I get mom in here when I need mom, right? Let me call her in here by throwing something on the floor. It's the early ages of pre-operational. Now, concrete is they have to know or have seen what's gone on before, and then they can sort of figure out from that. Concepts like, I know that in the past, when I'm good, I'm going to get a reward. So they know that. So they're going to be good for that reward. Now, formal operations is now they can take any situation, think about it, and figure it out in multiple different ways. I describe formal operations as that adolescent, like 11 and older. They're calling those adolescents in this stage of Piaget. Mommy said, I can't go to the movies on Saturday. But, well, in my mind, if I take the garbage out, make my bed, put my clothes away, get an A on my exam, I think I've done such good stuff. Mommy's going to let me. That's formal. Okay. So sensorimotor, we've just given some examples, right? We've talked about in the mouth, pre-operational. We talked about riding horses and brooms and throwing sippy cups and mommy comes, concrete operations. And now we're starting thinking about things like, why did I get sick? Again, we think that age group is still that I must have done something wrong, why I got sick, or why did my, dog die? Why can't pigs fly? They're starting to think about, well, they don't have wings. So now I'm starting to understand that. And I've already discussed that formal. Now they really can figure out with abstract logical thinking. Now, Erickson, you have to remember what Erickson says. Erickson's probably the most commonly used of all of the situations that we talk about theorists. So infants is trust versus mistrust. And why do I trust? Well, I cry, somebody gets me, picks me up, changes me, and feeds me, and burps me, and holds me. Mistrust, nobody comes. And I'm sitting here crying by myself, and nobody comes. And actually, they become this child that won't cry anymore. That becomes like that distant child that needs to have, some stimulation to get them back involved because the mom or dad or whoever is not, getting them. Then they go into the toddler stage where it's autonomy versus shame and doubt. Well, didn't I just say toddlers are mine, me? No. Well, autonomy means they want to be autonomous. They want to do it for themselves. And they're explorers. They explore everything. My dive bomb kids, right? They want to try to jump from the couch to a chair. They're going to do it, even if they get hurt. Now, what is the shame versus doubt? That's when mom and dad says, no, don't do that. They're trying to protect them from harm or injury, for sure, but they don't want to. So now they feel like, gee, I want to, but I should have, but I can't, and now they're doubting themselves, right? Their will is put down. They have to listen. Then I like to go into the preschoolers, initiative versus guilt. Again, now they're knowing right and wrong. They like to do things, they like to please, they're starting to dress, they can feed themselves, they're getting more, able to do more for themselves. But again, they feel guilty because, maybe they did something wrong. They're all into the Band-Aids and bleeding out if they've got a blooding, or again, God's punishing me. Now, when we talk about school-age children, probably one of the most of all of the Erickson is trust versus mistrust, and this is school age. Industry versus inferiority. Well, school-age children, we know, love to please. They don't want to be punished for things. That's Kohlberg, what he says. But the industry is, I can spell better than anybody, and I am the fastest runner, but I can't write. I have horrible writing, and, I don't know whatever. So industry is a task I do well. And inferiority is the stuff you can't, because they want to do everything well, because they like to please. And we talk Erickson on the adolescent. Just think about that identity. All of a sudden now they're told to choose a career, that they need to get into college, and then you have to fit into what social status you want. Are you the art kids, the music kids, the smart kids, the sports kids? You got to fit in. And then my hair's too short, it's too straight, it's too many freckles, too many pimples, I'm too fat, I'm too skinny. Do I like girls? Do I like boys? Identity like crazy. So when you think adolescent, they're looking for identity, and they are confused as heck. And you can understand by the way I just described it. So again, this goes into it that infants, trust versus mistrust, like I said, toddlers, learning autonomy is that potty training, self-feeding, dressings, etc. Those preschoolers, like I said, school age, again, industry versus inferiority. I'm great at running, I'm horrible at writing, whatever. And then, of course, the adolescents, all about body image, identity, who am I? Confused. Now, again, you're going to see Maslow, and it talks about the hierarchy of needs. We know we first need our physical needs met, food and shelter, right? And clothing. Then it goes for safety. Do we have the things we need to keep ourselves safe? Then it goes into needing to be loved and belong, family, friends, etc. And then esteem, I feel good about myself. So those are things that you're going to see in Maslow's, and then trying to choose what goes where. Now, Kohlberg. Kohlberg's all about right and wrong, or good and bad, and a punishment. And each child at different ages understands that. They're cognitively more aware of what that all means. So infancy has no clue. They don't know if they're doing good or bad. As they get older, they're starting to wanting to be rewarded for good behavior instead of punishment. Okay, they want good for themselves. They want that candy bar or that cookie or whatever. This is what they understand. School age, they want to be good. They want approval. They want those strokes. And then Kohlberg up there is all about, there is, they know right, they know wrong, but it doesn't mean that they're going to follow each. They're going to see what's best for themselves. I know it's going to be bad, but yeah, I'm going to do it anyway. Fractures, let's get into fractures. And again, this is this week's stuff that we're talking about. So knowing the types of fractures, green stick is you see an incomplete fracture on one side and then the other side's bent. So it's cracked, but this is sort of bent with it. That it'll need to be put and it'll need to be casted. Compound is when the bone comes out of the skin. Now these ones, the big thing is the word, because now you have a bone exposed to the world and it's gone through the skin, which has a lot of contaminants into the environment. So that one will need long-term antibiotics. Simple fracture, the bone is broken, but it didn't go through the skin. I mean, in children, it's usually, the wrist bones, either one or the other, poof, and they get these cracks because you put your hands out, right? You're going to put them out. So, and usually you'll fracture a wrist. Oblique, it breaks at an angle. So it's going to break up the side of one. Then we have the spiral. It's a sort of like a twisting type of motion, okay? You see this a lot in child abuse because, they grab them and they twist them to put them back, usually in the arms. You'll see those, and those will be the ones that you're going to suspect. Sometimes child abuse, what do you see? You've got a family that's, either with drugs, alcohol, some sort of abuse, could be social status, could be someone lost a job, or maybe they had child abuse as a young child. So some of those factors can contribute to child abuse. Now, a sprain is when a ligament's torn or stretched, and you will see it turn ecchymotic or bruised because you've injured blood vessels there, and they hurt and they'll swell. Go up and spike a volleyball, come down, take your foot and twist it, and you hear, well, that's a wonderful, horrible sprain that really hurts. Now, strain is, sometimes we do that for children who tend to overdo what their sport. Maybe say that the coaches go run for 2 laps and they do 6 laps because they want to be better. They've overworked something And they continually do that, then you're going to see little microscopic little tears there. And a contusion is you bump something and you're going to have blood showing ecchymotic area. These are all the types of fractures. So you can go back and look what it says, and now you've got pictures to show. So now let's talk, Let's talk about those issues with the bone. And we know that lots can go on with bones, okay? Number one, scoliosis, S-shaped curvature of the spinal column. What you'll see is one shoulder, because there's an S shape, so one shoulder is going to be pushed up. And you can see it. And that, of course, the other arm that the shoulder is down still, it's going to look longer than the other one. And you can see that when they're bent over, and you can see the S shape of their spine. Ewing's is a type of bone cancer, sarcoma, and you're going to see it in long bones. You can see it in the scapula. You can actually see it in jaw bones and then the other long bones there. Leg calf perth. Basically, it is the problem with the development of the head of the femur, and it is it's not an infection, but something happens where the blood supply is diminished, and it causes problems at the head of the femur, which that goes into the hip socket, and it's painful. And that tends to go away by itself with just rest and some ibuprofen. JIA, systemic autoimmune disease. You know, I've not made it a secret. I have juvenile, I don't have juvenile, but I have rheumatoid arthritis. And it's autoimmune. And what it is an inflammation of the joints, connective tissue, and viscera. And it hurts. You know, your joints are swollen, they're tender, they can get disformed. And they call oligoarthritis is when you only see it in a couple places, like 4 or fewer joints. These children are stiff in the morning, and they really need to exercise to keep those joints moving. Osteosarcoma is usually the long bones. You usually see that in the femur. Usually you'll see that in the adolescents. You'll see osteosarcoma. Duchenne muscular dystrophy. So muscular dystrophy is something going on with the muscles. The muscles aren't working the way it. Duchenne muscular history is usually in boys. Actually, we find it about ages 3 to 7. And what you'll see is now a child might start having a wobbly gait where they were okay, and all of a sudden they start wobbling and they get more and more weak. And then you're going to see their calf muscles get big and thickened because they're trying so hard with it. And that requires, in the end, wheelchairs on these kids and lots of therapy. Torticollis is when the neck is stuck to the side like a turtle. And it's the muscle gets shortened. The sternocleidomastoid muscle, which is the muscle in your neck. And you'll see it to the side, and it's painful. So now, let's talk about traction. And you're going to say, traction, what do we use traction for? Well, what we use traction for is to pull body parts apart so that they can get straight and they can be held steady. It is used to realign arms or legs, and it does help reduce the pain of a fracture before surgery. One of the most common that I've used in my lifetime is Buck's traction. And what it is a skin traction. So something is attached like a little boot, and it's a little ace bandage on the lower leg. And when you have a fractured femur, those two pointed bones go in different areas, different ways. And they're like little points, and they're sharp, and they cause them to hit the muscles and cause really bad muscle pain. So it pulls it out and straightens it, and it stops the pain and it stops those muscle contractions. And we use this before they go to surgery just because of the pain, because without it, these children are having severe muscle problems and pain. So Bucks is used for fractured femurs. So again, traction, it regained the normal length and alignment of the bone. So now we're good. It immobilizes and it reduces, means puts where it needs to be, that bone. It again eliminates those muscle spasms, because muscle spasms, those pointed things, are hitting nerves. So we're going to help reduce them. And of course, it helps prevent or reduce skeletal abnormalities. So there's skeletal traction, there's Bucks traction, all of those can be used. Most of the time, you're going to see mostly those skin tractions. Now, what is a neurovascular check? And why are we going to be checking neurovascular signs? Well, whenever you have a fracture or a break or even a really bad injury, the blood vessels can be occluded, and blood supply is not going to the toes or to the arm, to the fingers where it needs to go. So after we put, even before cast, on traction and after cast, we're going to be checking whether the toes or the fingers to see, is there pain? Okay, there should be some, but not extreme. Is there a pulse where there should be a pulse? If not, oh, what's the color of that extremity? Is it pale or is it pink? If it's pink, you got blood flow. If it's pale, you're not going to see it. And then paresthesia, is there numbness there? Numbness that, again, showing you that blood flow's not getting where it should. And then, of course, can you move it? If you can't move it, something's going on. So what would you do or tell a parent that all of a sudden this kid has no pulse, it's pale, and it can't move it, and there's numbness? They need to get to the doctor or to the ER right away, because that cast is not working right. If they're in the hospital, we're going to tell the doctor, let them know. So pallor, cyanosis to the distal fracture, which means down to the toes or to the fingers. If we see that, its circulation's been compromised. Cervical traction is for the cervical spine, where sometimes you get neck injuries and sometimes there's a fracture and you want to pull that neck straight, because it's going to, again, alleviate the pain and the nerves and put it where it needs to be. So this is cervical traction that's actually skin. It's just holding the skin there. They can put those things, metal clips into the skull sometimes, depending on the type of fracture that's going on in the neck. And then there's something called a Steinman pin. We use those a lot, that we put through the leg for fractured femurs, if it's a bad one that we need to pull out and have it more solid than just skin. Now, cerebral palsy. Now, cerebral palsy is a group of disorder that affects movement, muscle tone, or posture. Usually it's occurred to the brain. Something happens. A lot of times, cerebral palsy is right before birth or during having birth. And something happened that they're deprived of oxygen. Now, any child who had a time where they didn't get oxygen, let me give you an example. Let's say you're trying to do a vaginal delivery and it doesn't fit. They have to quick run to a C-section to get the child out. Well, there could have been a time where they didn't get oxygen, okay? That's one of the things. Or they're trying to get the kid out and they have to do everything, and they're finally do suction or whatever to get the kid out. This is when you see these children get deprived of oxygen. Now, these kids will be followed, but you're not going to really see them till, later on in infancy. And it could be at 6 months or 7 months. What would you see is they're not meeting developmental milestones. Something's going on, but these children will be followed closely, even way up to their preschool ages. Now, Cerebral palsy is either a floppiness or a rigidity. Spastic cerebral palsy is when they're shaking and they're trying to move and their muscles aren't working for them. So it's sort of involuntary. They'll have some unsteady walking, abnormal posture, and they just can't take care of their own muscles and movements. It's just really they're very tight muscles and they can't. So you're going to see all different levels of this, from mild to severe. Athetosis is that involuntary purposeless movement, which is that shaking. Let's say, for instance, my little Jonathan, I used to take care of him when I did clinicals for pediatrics. He'd see me and all of a sudden his hands would come up and he would just start shaking and he'd get this big smile on him. That is called athetosis, okay? Involuntary. It wasn't because he wanted to, it happened. And that spasticity could be arms, could be legs, it's anything. And that, again, as I told you, spastic cerebral palsy. When you think of cerebral palsy, that's the one that you think of. The ophthalminosis is an involuntary arching of the back, where their backs arch, and they arch back, and it's just muscle contractions, which is a type of CP. Now, pain scales. Now, there's there's 3 different types that we're going to use in pediatrics. Now, number 1 that we use is what we call the FLAC scale. And it just looks at the kid. And this is used for infants under the age of 3 or nonverbal. You can have an 18-year-old cerebral palsy child who's nonverbal, we can use it. You look at their face. Are they smiling? Are they grimacing? We're looking at the legs. Are the legs just there, just relaxed, or are they kicking and you can see something's wrong? Activity. Are they comfortable, or again, are they moving and trying to, get away from the pain is what I call it. Are they crying? And then consolability. And it works really good. The other pain scale is from 0 to 10. And adults, you've heard about that. Numeric, 0 to 10. 0's no pain, 10's the worst pain in the world. How do you feel? Well, there's faces that depict those numbers. And this is ages 3 and older. They don't go to numeric till age 8. But I'm telling you, kids, when they tell you what their pain is, they are going to point to the picture, and you could say it's probably more than what they say. And remember, pain is whatever and wherever they tell you pain is. Even if a kid is sitting there not crying, you ask them their pain level, they tell you it's a 6. It's a 6, okay? So there it is there. Our American Academy of Pediatric is, pain is whatever the client says it is, existing wherever they say it does. Now, what vital sign is pain considered? Years ago, we didn't even look at it all the time, but now we do it as the 5th vital sign, right? And it's something that's required that we ask them, at least once a shift, at least once. So tell me what your pain is and you document it. Now, opioids, this is morphine, this is Dilaudid. These are used and they're very safe to use in pediatric doses. It's used for moderate to severe pain. We use this for postoperative. If you had an appendectomy, let's say it ruptured, you hurt. We need to get you up and moving to prevent complications. We're going to give you morphine, an opioid. Sickle cell crisis hurts really bad. And of course, cancer. And we want it to work quick if we're using this. So the best way would be given intravenously. Now, acetaminophen can be used for mild to moderate pain. And children actually do really well with just Tylenol, acetaminophen. Another thing we're doing in pediatrics is using topical anesthetics. We start IVs today. We're going to use a numbing on their hand if we're finding a vein so that they feel touch and they don't feel pain. Because you're going to remember it's pain, pain, pain. So we try as much as possible to decrease it. Now, does anybody know what flumazenil is used for? Do you remember pharmacology?
It reverses benzodiazepine.
Yes, excellent. What reverses opioids? Narcan,
Narcan.
naloxone or Narcan. Excellent. Good job, guys. All right, the hospitalized kid. When does discharge planning begin? The moment you see the kid. Because you're going to be teaching as they go. You know that this parent's going to ask 100 questions. So that's your teaching. Now, this week's discussion question was on separation anxiety. Okay, knowing what they mean. So initially, if a child's crying and appears sad and depressed, which is the stage? It says initially. This is your protest, right? So knowing those different stages is something you'll need to know. How can you promote security? Now, I did write a message, a little my thing on the side to give you some more information. Get their favorite blanket, toy, or their favorite jammies or pillow or something. That helps them feel like home is with them, even if mommy can't be there all the time. And always incorporate some sort of home habits. Keep them on the routine they're used to. Find out what foods they like, if they can eat those things. And all these things help reduce anxiety. Now, when would you see a level of consciousness in children that's altered? They're just not awake and alert the way they should. What is one of the symptoms that you'll look at? And it's a low blood pressure. Why a low blood pressure? You're not getting oxygen to the brain because the blood pressure is too low, right? Very simple. So we as nurses have goals when caring for hospitalized children. What are some goals? Well, we know we have to reassure the parents and we need to let them know what's going on. We're teaching, right? We're teaching. And that's from admission, right? Maintain a sense of trust. Absolutely tell the kid when it's going to hurt. Don't tell a kid it ain't going to hurt when you know it does. I did a lesson today in another class about taking chest tubes out. It burns when it comes out. Let them know that it's going to hurt, but you'll do everything possible to minimize that pain. Always provide individualized and flexible nursing care. Not every child with a broken bone is treated the same. I mean, we all have our own ways we do things. For a separation anxiety child, we want to put the same nurses there. So it shows some consistency. But remember, having some diagnoses with more flexible can help. Try to put home habits, transitional objects, again, like the blankie, the jams, etc. Try to maintain that home routine and, soothing techniques. Play with your kid, get them through these horrible experiences with distraction, right? So the eyeball. What can go wrong with the eye? Well, lots can go wrong. Number one, an infection, pink eye or conjunctivitis. That is an inflammation of the mucous membrane that lines the eye. We treat it with antibiotics. Some other things that you need to know is hyperopia and myopia. Nearsighted, farsighted. I can't see close, I can't see far. Glasses are required. Amblyopia is also called a lazy eye. How do you treat a lazy eye? Well, you make it work. You patch the good eye. Let that lazy eye, those muscles work and get stronger. Strabismus. Both eyes can't focus on the same thing at the same time. That is strabismus. And nystagmus is when you see the eyes sort of moving side to side. And pallidemia is when your optic nerve gets swollen, and this is going to cause visual disturbances. All right, let's talk about some ears. Hearing loss is something that you're going to find And it could be because a child's speech isn't good. It's like, this kid isn't speaking good. Well, is it hearing loss? A lot of times it could be. So what are types of hearing loss? Well, congenital, something they're born with, hereditary, or it could be from an interuteral infection and it gets in the ear and it causes damage and they can't get their hearing back. Sensorineural hearing loss has to do with the cells of the cochlea and the acoustic nerve, and they're damaged. So they need to have those repaired to be able to hear. Ever hear of cochlear implants? That can help them hear. Conductive hearing loss is when the tympanic membrane doesn't allow sound to go to the middle ear, and then you can't hear it. So, nursing care. You've got a child that you know is hearing impaired. What are you going to do? Well, go face to face with the child. They might have be able to read some lips. Always be at the level of with them, and always be eye to eye, and talk in very short sentences. You do not have to yell, okay? It's like you're yelling at them. What's an acute infection of the external ear canal called? Anybody know? Otitis externa. Yes. There's media, middle ear, externa is the outer ear. It's also called swimmer's ear, the other name for it. So what's an acute infection of the middle ear called? Otitis media. And how do you treat that one?
Antibiotics.
Oral antibiotics. The acute infection on the external is usually eardrops, but the inner ear is antibiotics. Good job. What is a seizure? Well, I describe the seizure as somewhere in the brain goes bzz, and it doesn't like what's going on, and it creates something. And remember, depending on where it is, depending on what you're going to see, but you can see from completely moving myoclonic, the grand mal, which is the tonic, clonic, muscle jerking. Your breathing is irregular. You could lose your, urine or your stool. And when that's done, you're going to be confused and probably sleep. Petit mal, sometimes could be a little blank stare. This is one of the ones that is very hard to diagnose. All of a sudden, you stare off and, and you think they're just not listening to you. It could be a seizure.
We had a patient at the last job I worked at. We thought they were faking. We thought that they were faking, like ignoring the nurse.
And they were having little.
They were actually having this type of seizure.
Wow, that's amazing. Yeah, a lot of patients are misdiagnosed for things like this because there are you wouldn't think of that blank stare, especially if their behavior is not good all along too. So
right. Yeah.
Jacksonian is a simple partial seizure that starts in one area. Could be an arm, a leg, a face, and they're awake and alert and know what's going on. Myoclonic is jerking motions on awakening, and then sudden you just collapse, and then you're okay within a minute. Status epilepticus, most dangerous of all. These children, adults are prolonged their seizure. And remember, these children, you worry about oxygen and breathing. And many of these children, require medications and et cetera. And will require lifelong medications usually. But they describe it prolonged and it doesn't respond to treatment after 30 minutes or more. And then postictal period. What does that mean? Well, that's the time after a seizure where they're just a little disoriented and maybe sleep. Postictal. That's all that means. So what causes a seizure? Well, could be anything. Infection, fever, drugs, they could be epileptic. It could be hypoglycemic. You've heard of febrile seizures, right? That can cause them. They'll grow out of them, thank God, but it is one of them. How do you, as a nurse, you walk in, your kid's having a seizure. What do? Well, put the side rail up. If there's anything in the bed that can hurt them, get it out of the bed. I usually will take it and I'll pull the bed out of the wall and throw it over the front headboard to get them out of there, because you don't have time, just you want to move things quick. If a child has seizures, make sure that they have an ID bracelet on. You know, today we've got cell phones that have this information, but sometimes you don't get that quick enough. A medical ID bracelet or a necklace, something. Make sure that parents and children, both old and children that are old enough, know they need to be compliant with the medications, because if their drug levels get low, they're going to have a seizure. And then if a child is doing things like swimming, they can have a seizure in the swimming pool. Make sure that there's somebody there supervising. They can't go alone. So know your medications, know how to calculate pounds to kilograms. And then if they're asking for a dose, 4 milligrams per kilogram, you'll multiply their kilograms by 4, and that's going to be your answer. Also milligrams per ml, dose have, availability, and of course, know your mLs per hour for your IV sites. I do have a YouTube channel, and I send it to everybody. I send it to all RN and PNs. The YouTube channel is very simple, and you have some worksheets about it. So I wish you good luck. If you need anything more than that from me, you just let me know. I'll be here to help you. Any questions?
Thank you so much.
Thank
It's
you. very much.
always my pleasure. Thank you so much, guys. Have a good night.
You
Thank
too.
You too.
You too. Thank you.
You're very welcome. Thank you.